give a second for people to file in.
Yes.
Perfect. Hello, everyone. Welcome to tonight's webinar presented by TMFD Academy. Tonight's webinar will be the Dentist's Guide to Understanding the Prevalence, Diagnosis, Etiologies, Prevention, and Treatment of Peri-implantitis. Tonight's webinar will be hosted by Dr. Murray Arlen. My name is Zach Sloan, and I am, along with my colleague Carla Fernandez, I'm a financial advisor with TMFD Financial, where we focus in coordinating tax, investment, and business planning to help our dental clients achieve their financial goals and financial independence. Through TMFD and our investment arm, Asante Financial Management, we've managed to serve hundreds of dentists and help them along their financial career to help them achieve their financial independence through our holistic financial planning. Carl, if you'd like to take care of the housekeeping items.
So before we get started, just to cover off some of our housekeeping items. So for this evening, if you have any questions, you can just check along the bottom of your screen and just place your questions in the Q&A box. If you just want to chat with Dr. Arlen, myself, or Zach throughout the evening, you can place any of those comments in the chat box. Also, there'll be some questions that will pop out throughout this evening's workshop or throughout this evening's webinar. And you'll see those on your screen. You can just answer those questions. Also, as it relates to the CE credits, the CE certificate will be emailed out to all of the attendees within about 2 weeks of tonight's event. Thank you.
Perfect. So to introduce tonight's speaker, Dr. Murray Arlen has been practicing dentistry with his specialty in periodontics for over 40 years and has numerous publications in the fields of both periodontics and implant dentistry, as well as having lectured internationally on those same fields. Dr. Arlen is a co-founder of the Toronto Implant Study Club, as well as being a founder of the Dental Hygiene Periodontal Study Club of Toronto. Dr. Arlen, take it away.
Okay, thank you very much. I'll share my screen while we're chit-chatting. I want to thank Zach and Carla for the introductions, and thank TMFD and specifically TMFD Dental Academy for putting on these seminars and for having me speak here tonight. If anyone wants to contact me by email, I'll put this up again in some other slides. Feel free to contact me, murray@murrayarlen.com. Plus, there's several articles that you may be interested that I can email to you as well. Carla mentioned that we'll sprinkle 7 different questions throughout the seminar, multiple choice answers that are important for you to document that you've answered them, to show that you're in attendance in order to get your CE credits. Your answers are not being monitored. It doesn't really matter if they're right or wrong, and all that matters is that you've answered them. We're going to go quickly, so answer the questions as quickly as you can, and we'll try to get to as many questions as possible. So I do want to, again, thank TMFD, and as you probably know, the Dental Academy is a series of free evening webinars, usually about 50% on clinical dentistry topics, 50% on financial related topics. We are approved for continuing education. As a disclaimer, I do want to say that I've been an extremely pleased and happy client for TMFD for over 10 years. Honestly, I think they're fantastic. Any of you who are not clients, I guarantee you'll never be sorry if you become one. I'm not being paid to say this specifically. Please take a moment and look at my testimonial on the website, where I really go through the whole kind of procrastination process. I'm sure all the hesitations I've had are common to most of you. So again, big thank you to TMFD, and we're very excited about the TMFD Dental Academy. So we're talking about peri-implantitis, and in case you don't know what that can look like, here's a little shocking example to get us started. I will say that any of the cases I show are mine unless I state otherwise. This is actually not my case, but I'll show you plenty of mine as well. And what we want to chat about are these areas. We're going to go through them one by one. This program is being recorded. I will go at a fast pace, but you can go back to these recordings. So why are we really concerned about peri-implantitis? Well, it's one of the most common complications in implant dentistry, and complications are increasing. There's even textbooks about it. Why is that? Well, I've listed here many of the reasons why. More implants are being placed each year. More by general dentists. There's more growth in implant placement by general dentists in the last 10 years than by specialists. But specifically for peri-implantitis, now some of our patients have had their implants for 30, 40 years, and peri-implantitis increases over time. So all dental offices, dentists, dental hygienists, even if they don't place implants or even if they don't restore implants, will be seeing peri-implantitis patients coming into their office and really need to know how to deal with these patients and know what's going on. This is my father. I'm going to show you an example of how late failure and peri-implantitis can sometimes take years to develop. So on your upper left is, I placed these implants. It's significant that they were what's called a TPS surface. This company now has a better surface called SLA or SL Active. And these were more prone to late peri-implantitis. But look what happened. 6 months, everything looks pretty good. By 7 years, the middle implant is showing some bone loss. Look on the lower left, by 10 years, it's more severe. And by 11 years, it's just getting worse and worse. And my dad had a heart condition, and we didn't want this chronic inflammation, and we couldn't really treat this. So here's again what it looked like at 11 years clinically, probing a very deep pocket. You see the pus coming out of the sulcus. So we basically took this bridge off. It was screw retained. I easily removed the middle implant and put the bridge basically back on, and later redid the bridge and converted that middle one to a Pontic. So fortunately, we had sufficient implants that we could remediate and salvage the case without having to redo the implant. But the point of this discussion is late bone loss can take place over a period of many years sometimes, and these patients will be showing up in your office with more and more frequency. So a little more disclosure. Again, I was in private practice, restricted to periodontics and implant dentistry. I'm not married to one particular implant system. I've used over a dozen designs over the years. I treat the surgical. I do not do never did the restorative aspects. As I said, all cases are mine unless stated otherwise. I am not employed by any company. I'd like to think that I can give you a relatively unbiased viewpoint. And but I do want to disclose that TMFD has done some sponsorship for today's lecture. So, really, I want to try to make this lecture a good learning experience. Keep it casual, have some fun, and certainly throw in lots of juicy cases, make it very clinical, not to be bored. So on a more serious note, the list of objectives, I want to provide you with an evidence-based approach. And we want to review, as I say, the diagnosis, recognition, prevalence of peri-implantitis. We want to review what are the risk factors to anticipate a higher risk for patients getting peri-implantitis. We'll quote the literature. I'll also share with you my private practice experience because I've placed and followed over 15,000 implants for up to 30 years. So I have lots of personal experience. We'll talk about not just preventative treatment, we'll talk about surgical and non-surgical treatment as well. So try to have a well-rounded approach. Keep in mind that we have only about an hour to cover all this material, and we'll go at a fast pace. And obviously we can't cover everything. I would like to have at least a 3 or 4 hour lecture to really go into every minute detail. So I mentioned we want an evidence-based approach, and that's a combination of certainly published studies, good quality ones. I mentioned my own clinical experience. We're going to look at some studies that are what's called systematic reviews and meta-analysis, which is combining a lot of studies together for a more powerful result because the numbers would be much higher. And we'll quote some of the important world workshops and consensus conference and journal articles. Again, we want to make this evidence-based lecture as much as possible. I'm not going to dwell on this slide, but some of you may have heard that there's different types of studies that have different levels of credibility and strength. Something called a randomized controlled trial, prospective, double-blind, placebo. These are terms you've probably heard. Those are studies that are done in very strict funded studies, often by the commercial companies. Whereas this big blue arrow is more my own study of my own 15,000 implants followed for 30 years. It's not as high up on the pyramid, but it is real private practice conditions. It's not some artificial commercially funded study where they may only choose the best circumstances. So it's still powerful to show these private practice experiences. And I mentioned you can email me if you want me to send you any of my articles that I've published. Specifically, there's 5 of them on risk factors, but many of them related to peri-implantitis, or my most recent article on my 30-year experience with 15,000 implants. For my own data, I'll just mention briefly that I've managed to be able to come up with all these statistics and data with the help of a special software system that you'll see from some of my statistics, in case you're wondering how I managed to, compile all that. So let's start off with some definitions. What is peri-implant health? Basically, absence of signs of inflammation. What is mucositis? Well, you've got kind of similar to gingivitis, you've got inflammation, bleeding, but there's no true bone loss. Once you're getting into the definition of peri-implantitis, the main differentiating feature here is now you've got certainly the inflammation of mucositis, but now you've also got loss of supporting bone. This last category we won't talk about is when you have a edentulous ridge deficiency, for example, which is not really part of the discussion today so much. So visually, peri-implant health, visually at least, you don't see signs of inflammation. With mucositis, you're going to see bleeding on probing. With peri-implantitis, you're going to see bone loss. And that last category where you have ridge deficiencies will often result in recession, and maybe you can't even place the implant if the ridge is collapsed enough. So let's go to our outline and start off with recognition, which we've already started on that. How do you recognize or diagnose when your patient has peri-implantitis? Well, first is visually. Obviously, you're just looking. The 2 top cases are examples of periodontitis with natural teeth, and the lower left and lower right are the same case of a patient with some obvious plaque and recession. And when you look at the radiographs, you can see that they have peri-implantitis. So here we're looking at visually, recession, inflammation, bleeding, and here we're also looking at it radiographically where we can see true bone loss. So again, how do we evaluate or recognize it? Well, clinically, we just said, visually, you're going to look at things as we just did, but you're also going to probe, just like you would probe for natural teeth. Now, some of you will say, oh, we're using a metal probe. Is that safe to use a metal probe? And we'll come back to that shortly. And we're going to look at radiographs. Just like I said before, you will see the bone loss on the radiographs. And there's something else as well. You also want to check for mobility. Any dental hygienist or dentist should every single time firmly luxate with 2 mirror handles the implant restoration and see if there's any mobility. If there's any mobility at all, even slight mobility, something is wrong. And it could be the whole disintegration of the implant. And commonly it's not that. Commonly it's one of the prosthetic components is moving. You either have a loose or broken abutment screw. If it's a cemented restoration, you may have lost your cement seal. You could even have a fractured implant. So very important to check for mobility every single time the patient comes in. Equally important for the hygienist to know this as well as the dentist. So the dentist then has to figure out what it is. And you want to do that as soon as possible, because let's say there's a loose abutment screw. If you leave that there, it's like the broken clip, a paper clip. If you bend it back and forth, eventually it breaks due to metal fatigue. The same will happen with a loose abutment screw. It's much easier to remove and replace a loose abutment screw than to wait until it fractures and then maybe not be able to fish out the broken piece that's left deep down inside the implant. It's very important to educate your patients on this, that if they ever notice any looseness, even a little bit of looseness, to come see you right away. Because to the patient, they'll typically say, yes, I noticed it was loose, but it wasn't hurting me, it wasn't bothering me. So I didn't think there was any rush to come in and see you. So very important to educate your patients. Every single implant patient should be educated on this. Another problem with loose abutments, and this is my case where we had the same patient on one side, no significant pocket depth and mobility. On this side, maybe you can't see it, but there's a little opening there, and the abutment screw was loose. And that creates this micro gap that opens and closes or pumps bacteria in and out. And that will lead to bone loss and peri-implantitis. And this has been shown in studies. And this is one clinical example of that. So loose abutments can lead to peri-implantitis. It's not just the loose or broken or potentially broken screw that we're worried about. So when we evaluate implants, to summarize, we want to look, we want to probe, we want to do radiographs, and we want to check mobility. So let's look at these in a little bit more depth. So probing, first of all, just a reminder of the histology. On your left, we have the natural tooth, and on your right, you have the implant. And we know that we don't get a true attachment of Sharpie's fibers going into the cementum, when you have an implant. You more or less have a connective tissue. I'll use the term adhesion, almost like a glue-like adhesion, but not a true insertion of fibers. So it won't resist probing as much as a natural tooth. So when you probe a natural tooth in health, your probe will typically get stuck within the junctional epithelium, whereas with an implant, when you probe, it typically will penetrate into the connective tissue portion to some degree. When you have inflammation, the probe will go deeper in both situations. The problem with probing, so as I say here, the probe goes deeper if you have inflammation. The problem with a lot of fixed implant restorations is sometimes the access can be extremely difficult. And sometimes you can't even really get proper probing depths, especially if you have more of a ridge lab prosthetic design. So we have to appreciate that getting accurate probing depths can be very difficult, sometimes really impossible. And I would say when you're monitoring longitudinal attachment levels, I would say probing is less reliable for implants compared to the natural teeth. So you can't rely on probing too much for implants. You can use a metal or a plastic probe. The plastic probe sometimes is helpful to get into difficult to access areas. The metal probes, even though some teachers have dogmatically taught you that metal probes are not safe to use because they scratch the abutment, this is a sort of dogmatic, unproven kind of stuff. And studies have since shown that there's no lasting effect or damage to the junctional epithelium. By day 5, you're right back to normal. So this might be very dramatically different than what you've been taught, but metal probes, in my opinion, are safe to use around implants. Now, what about radiographs? Radiographs are really important to try to monitor bone loss around implants. So just the way probing is maybe less reliable for implants compared to natural teeth, for radiographs, I'd say it's the opposite. Radiographs are perhaps more important to follow longitudinally if you're getting ongoing bone loss with implants. But it's really important that the implant is taken at the right angle perpendicular to the implant. With a threaded implant, when the threads are obscured, it means the angle is not coming in at right angles. So here's a follow-up radiograph taken at the correct angulation, taken at the same time. And you can see what a dramatic difference you're seeing in the bone loss that's actually there. But in the poorly angled radiograph, it's being masked by the poor angulation. So here you can see the threads clearly. And that's a sign that the radiograph has been taken at the correct angle. So I know it's hard sometimes to get those big digital sensors properly positioned in the patient's mouth, and we don't want to hurt our patients, but they really do have to be positioned properly. When would we take radiographs? Immediately after the restoration, especially if you're cementing a restoration, because residual cement can be a significant problem. And we'll talk more about that later. You want to have a good baseline record. During ongoing recare or maintenance, whatever you want to call it, if you're seeing dramatically increased probing depths, a lot of bleeding, suppuration, you may want to take a follow-up radiograph. It's not an exact science, so you have to use your judgment when how frequently follow-up radiographs should be done. So let's step back a little bit, and we talked about, we're talking about radiographic crestal bone loss and all the other things we look at, but let's talk about bone loss for a moment in sort of the bigger picture. And I ask you the question, why do we care about bone loss? And you might say, well, that's a dumb question. The answer is obvious, but I can think of 5 different reasons why we would care about bone loss. And maybe you could shout out what are the 5 things, the 5 clinical effects of bone loss. I can't hear anybody. I'll stick to Peri. I'm not a good Canadian. Well, of course, if we have bone loss, we're going to have deeper pockets, and usually with that we get bleeding, exudate, and the patient may even have symptoms or pain. Something you may not have thought of is with a lot of bone loss, we often get recession. And if that's in the anterior part of the mouth, that can cause some real aesthetic problems. We could ultimately have loss of the implant, like that very first slide I showed you. Maybe you also didn't think about, when you get a lot of bone loss, the implant is so unsupported. If there's just 5% at the tip holding a bone, holding the implant, then the implant can actually fracture. And if the bone loss is bad enough, you could even get mandibular fracture. So I'm sure you thought of some of these things, certainly the first one, but maybe not all 5. So let's look at these quickly. The one that's most obvious. Here we have a deep pocket, and along with that 8mm pocket, we've got bleeding and often suppuration as well. We looked at this case before, where with mobility of the abutment, long-standing, we can get bone loss here. So again, we want to have our radiographs to help alert us, why do we have a deep pocket and why do we have bone loss? And sometimes you can even see the little gap that's open there. The second of the 5 was aesthetics. So again, if you have, and this is not my case, if you have a lot of bone loss, who's to say the papilla is not going to shrink along with that bone loss? And here we can see some recession and lack of papilla and a real serious aesthetic problem related to that bone loss. Implant loss, I showed you that case before. It's obviously an exaggerated example, but certainly that can happen. Now here's one that's a little different, implant fracture and bone loss. It's an interesting relationship because sometimes the implant fracture can occur and then the fracture causes the bone loss, much like the loose abutment could. Other cases, sometimes you get the bone loss first and then the implant is so unsupported that the implant fractures later. So 2 totally different situations related to implant fracture. So this is an old basket kind of implant that I did not place, but it was there for about 25 years. And all of a sudden, on year 26, the crown was loose. And it turns out the implant was fractured right here through these vents. But suddenly, at the time of fracture, the bone really, there was a lot more bone loss. Look at the mesial here. And like maybe a month later here. So this sudden bone loss, in my opinion, was caused by this fracture. And there you see the residual piece that was left behind. So that's one type of fracture. The other one, and this is a very unusual case of a fractured abutment. The dentist tried to, this was an old case where the abutment was cemented with permanent cement and a non-precious metal. The dentist overheated the implant by trying to drill out this abutment, and there was no bone loss for 5 years. And 2 weeks after he drilled this out, we got all this bone loss. But that's not why I tell the story. once this whole implant had this very unfavorable, call it crown to implant ratio, nothing was supported above my arrow here. So the implant just shortly thereafter snapped off. You can see here the fracture. Turns out I removed this broken fragment and redid the case, but this was one of those cases where an unsupported implant can fracture. Now, do you remember what the fifth one was? Mandibular fracture. So if you're presented with a case like this, and this was my case, patient showed up after maybe 15 years of not seeing them, and what would you recommend to this patient? Let's say the patient is asymptomatic. They just came in to say hello, and they weren't even aware that there was a problem. What are you going to recommend? You say, well, let's monitor only. I mean, the patient's asymptomatic. Maybe they'll move to Vancouver before, you know, any problems occur. Maybe, God forbid, they'll, you know, pass away if they're old. Sorry, that's very poor taste. Okay, would you just monitor only, not bothering the patient? Why do anything? Or would you recommend non-surgical therapy? Let's try to give some freezing and really scale and replate. That's not going to work. Would you recommend periosurgery? And we'll look at some periosurgery techniques at the end of this presentation. But I'll tell you right now, I don't think surgery is going to help in case this advanced. Would we remove the implants only if the patient is willing to redo the implants? Because right now those implants are functioning for the patient, and they're not having any symptoms. So we don't want to remove the implants maybe if the patient's not willing to redo them, because now they're going to have no retention for their denture. Or do we suggest that we remove the implants regardless of what the patient commits to? What would your choice be? And I would say your choice should be the last one. And I gave you kind of a hint of that by saying, now we're going to talk about mandibular fracture, because it can happen. This is my patient. I placed these implants. They came in for a 1 and a 2 year follow-up. And then I didn't see them for the next 15 years. Their name's on the schedule. And guess what? They're not here to say, hello, Dr. Arlen, I missed you for 15 years. I thought I'd come by just to say hello. No, they've got a problem. And one implant had already fallen out. And the other one, you know, had this tremendous bone loss. And I was really worried that this patient might have a mandibular fracture. So regardless of whether the patient was willing to redo those implants, I strongly recommended the implant be removed, both sites be curetted out, because this was just exfoliated on its own. It was full of granulation tissue and pus, and we did clean it out well. We could do a bone graft if you want, but the bottom line is we got that bone to regenerate, and hopefully the patient would be willing to redo the implant. So there are cases where I think you should recommend strongly implants come out if mandibular fracture is at risk. Now, can this really happen? Well, here was a study of almost 500,000 implants placed, oral surgery hospital. Now, there were 237 jaw fractures, over half of them associated with the type of cases that I've just shown you. So let's say there was 150 or 125. Based on 475,000 implants, it's not very common, but you don't want one of those to be your patient. So keep it in mind. It's unusual, but keep it in mind. So here's our first question, folks. Everyone should select an answer. Carla's kind of monitoring this. So just to read the questions. Peri-implantitis is increasing. Why? What is the best answer? More implants are being placed. Some people taking courses have inadequate training. Peri-implantitis increases over time. Or is it A and B? Or is it A, B, and C? Carla, are you going to post the results?
Yes, we'll just give it another minute or so to allow some more responses to come in.
On time. Yeah. Okay. Right on time. Remember, folks, don't worry. It's not, no one's keeping track if you got the answer right or wrong. We want to document that you're here and that you're responding. Okay, I think we've given enough time, Carla. Can we tabulate what the results are so far?
Can you see those up on your screen?
Yeah, I can see. So 81% of you chose all three, and that is correct. All three were mentioned in the one of the early slides I showed you when I showed you that textbook on why complications are increasing. We have three questions here, so let's carry on. What is the best answer? Recognizing peri-implantitis may include visual and clinical observation, peri-implant probing, radiographs, mobility, or is a better answer all the above or none of the above? Carl, I think we should have some music in the background. What's that game show? Da, 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 da,
Jeopardy.
Jeopardy. Yeah, we should have some Jeopardy background. Final Jeopardy. Yeah.
I will make
Let's try to do that for next time. That would be cute. Okay. What do we got, Carla?
We still have some responses coming in. We'll give it another minute or another few seconds. We have almost 80% responses.
Okay, I think, well, all right, I'll leave it up to your discretion.
There we go.
All the above, 94%. Yes, so those are all things that we utilize to recognize. We look, we probe, we radiograph, we check for mobility. E, all the above. Okay, so let's move on to the next question now. What is the best answer? The effects of bone loss may include peri-implantitis severity, recession and aesthetics, implant loss, implant fracture, or all the above or none of the above. Da, 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 da. I'll stick to perio and implants. Okay, how are we doing, Carla?
At 75% responses. We'll just give it another few seconds here. Okay, and I'm going to end the poll and we'll share the results.
All of the above, 98%. Very good. Yes, all of these things are the 5 clinical effects you may have from bone loss, even though not all of them are maybe the most obvious. So let's move along now to prevalence. This will be a quick, easy one. How frequently do studies document that you'll come across mucositis and peri-implantitis? There's a huge range depending on which study you quote. If we just take the average from a bunch of different studies for mucositis, it's almost half of the patients will have at least gingival inflammation, bleeding on probing, and 22% on average would have true bone loss. Again, of course, it can range in severity. And like we said, the longer you go, the more serious it gets. I really like this study. Ignore the bottom third. Just look at this top study. I like that because it looked at patients for more than a 25-year follow-up. It's significant that, again, it's these TPS surfaces. That's the same rough surface I showed you that case on my dad that had a higher incidence of peri-implantitis than Straumann's implants today are either SLA or SL active, which cut out roughly 50% of peri-implantitis. But nevertheless, if you look at the failure rates and the prevalence of peri-implantitis at 10 years, it goes up to at 15 years and it's higher at 25 years. So you can see that there's a steady climb, not just in the failure rates, but also in the prevalence of peri-implantitis over time. And this is done a combination of 7 practices in their data. And remember, it's hard to get patients to come in for these long follow-ups, so it's hard to get large numbers. I do want to say, as I mentioned, that Straumann has changed their surface now to SLA and SL active with much, much lower rates of peri-implantitis. Let's move on to etiology, and risk factors sort of ties in with what's the cause of peri-implantitis. Well, it's similar to periodontitis in many ways. There's many risk factors. Plaque is certainly, the primary one, but there's many risk factors that can influence whether the plaque causes damage and how much. Risk factors in implant dentistry is my favorite topic, and I actually have, believe it or not, 30 hours of material on the subject of risk factors in implant dentistry. So I'm going to show you this slide, and don't let your eyes glaze over. We're not going to cover every one of these items. That would take 30 hours. We just mentioned plaque control. If you just ignore what's below this white line, I look at risk factors in 4 broad categories. Risk factors related to the patient's systemic conditions, such as their health, medications, do they have a history of periodontitis, do they smoke, etc. The second category being host local factors, such as the patient's bone quality and quantity and their plaque control, for example. There's a third category of risk factors related to the operator, like did they do traumatic surgery, overheat the bone and cause bone loss? And the fourth category is biomaterials. So is the implant materials that you're using inferior? So we're just going to hone this down for our discussion today into these risk factors. And we're not going to be able to even cover all of these, but we'll cover some of the most important ones. So the number of check marks indicates the strength of the risk factor as it relates to peri-implantitis. So if patients don't come in for professional maintenance, that's a strong factor. If the patients have a history of aggressive periodontitis where they lost all their natural teeth at a young age, that's a strong one. Plaque control is the strongest of all. The implant design and surface, and I mentioned that TPS surface is now replaced by the better SLA surface. The prosthesis fit, and remember I showed you those loose abutments causing bone loss. Iatrogenic things like excess residual cement, which is a big one. And here are some others I've listed, but we're not going to be able to get to all of them. We'll cover most of the ones on the left-hand side. Let's start off with plaque control. And remember, I showed you that slide. Well, there's a little plaque there. Of course, plaque's not the only thing, but many studies have shown with poor oral hygiene, you're going to get a much higher odd of having peri-implantitis, like 14-to-1 odds in this particular study. Or I like this study too. Is amazing that when they looked at the percentage of peri-implantitis as it correlated to the patient's oral hygiene, when they had good oral hygiene, there was only a less than 2% incidence of peri-implantitis. When they had moderate oral hygiene, it was 5.72. When it was poor oral hygiene, it was way up there at 13.4. So there was a very strong kind of obvious correlation. The worse the oral hygiene, the more the peri-implantitis. And the same held true, worse oral hygiene, more bone loss. There were many other factors studied, but right now we're talking about plaque control and oral hygiene, how that is the strongest risk factor. So we have to keep emphasizing the importance of oral hygiene. Let's move on to another risk factor, and we talked already about prosthetic fit. Remember I showed you those loose abutments, and I said if you do have mobility, you need to check out, is that disintegration of the implant, or is it one of the prosthetic components that's broken or loose? Because remember, a loose screw can lead to a broken screw, and what else can it lead to? Bone loss. Remember I showed you that? So a long-standing loose micro gap at the abutment joint can pump bacteria in and out and lead to bone loss. So the type of implant system that you use, the type of prosthetic connection that you use is important. You want to have the type of prosthetic connection that tends not to loosen. And frankly, that would be a conical attachment. Now, the other highlighted risk factor was residual cement. This is an old version of a cemented abutment. You see it's not fully seated, but the point of my showing you this case is there's this deep pocket, 8.5 millimeters, and I took out a big wad of residual cement. This is a big problem, I think. I do see some dramatic cases where the dentist did not recognize that they left some cement over. I always try to get patients back after they complete the prosthesis and thereafter annually, so I can do my clinical study and also try to do a good job for the patient. So very often the dentist has not taken a post-insertion radiograph, and so we catch these sometimes. And sometimes these are very difficult to get off. Here's another case by Dr. Mark Nicolucci, where he placed this implant at a nice bone graft. Everything looked great. Shortly after the crown was put in, the dentist complained that his bone graft was lousy because it didn't hold up and he had all this bone loss. But when he flapped it open, all this residual cement was there. It's a more common problem than maybe what we realize. It's a very dramatic example of humongous gobs of residual cement left over. You could see it here on the radiograph. Several days after cemented crowns, it looked okay. I asked the dentist to try to get the cement off. He did not, or he tried, but unsuccessfully. And within a few years, we had this tremendous bone loss. Here's another case where I requested that the dentist remove this excess cement. 5 years later, nothing was done, and the bone loss is continuing worse and worse. There are many studies to show the detrimental effect of excess cement and bone loss. Here's one of those systematic review and meta-analysis, combining 26 studies together to get a very large sample size of over 1,000 cemented restorations. And their conclusion was excess cement was a risk factor for peri-implantitis. There's many studies we could show you on this. I do want to give a call out to my colleague and friend, Dr. Emil Svoboda. Some of you may know of him, a general dentist who's a real expert on implant dentistry. And he has developed the reverse margin. And I would encourage you to look into this. It's a way of, when you're placing a cemented restoration, instead of a regular chamfer or bevel chamfer, the actual chamfer comes up a bit. So the excess cement is extruded supragingivally instead of being pushed down subgingivally. I'm sure I'm not doing justice to the proper explanation, but you get the idea. So I mentioned implant design, again, is another issue. And I showed you a case where the loose abutment joint can lead to problems. There's many studies done on different designs. You have an external hex, you have an internal hex, you have internal conical connections. The bottom line is, I think everyone will agree that the studies have shown that conical connections have been shown to be superior connections in terms of creating a tighter seal with a smaller micro gap and less likelihood of showing any of that mobility in the micro gap that can lead to this kind of thing that I showed you before. So if you're open to selecting an implant system, I would suggest one with a conical connection. Of course, that's not the only thing to take into account. I do want to give a shout out to the Neodent system, which is a Straumann-owned company that in the latter part of my career, we favored using this conical connection called the Grand Morse taper connection. And I thought this was an excellent implant. The point being here that it's the conical connection that is the least likely to have loosening. Do you have time for another question? Just a single one this time. What is the best answer for those risk factors that we've touched upon? History of periodontitis, is that a risk factor? If the patient has a history, I'll include the word aggressive periodontitis. If they have poor plaque control, is that a risk factor? If they have loose abutments, if they have residual cement, or is the best answer all of those or none of those? Da, 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 da. We're doing quite well. We're a few minutes ahead of schedule, so we're doing well.
We'll give it another 20 seconds or so.
Okie dokie. We have a nice turnout tonight. I see 26. Are there 26 questions in the chat box, or
No,
I'm not monitoring the chat box?
No questions in the chat box, just dealing with some tech issues.
Okay, okay.
So no questions.
Don't be afraid to post questions in the chat box, folks. Well,
In the Q&A box.
in the Q&A, my apologies. That's why I'm not running the tech here.
I'm going to end the poll now.
Okay,
And we'll share the results.
all of the above. Yeah, all of those are risk factors that we just finished talking about. Thank you. Okay, so just to summarize, we've looked at a bunch of risk factors. We couldn't cover all of them. If you invite me back for a longer lecture, we'll of course go into all of these. It doesn't have to be a 30-hour lecture. We can condense it as necessary. So now we're moving on to the last two sections, kind of getting into treatment now, preventative treatment, as well as, let's call it, active non-surgical treatment, active surgical treatment. We're going to touch on all of the above. So when we talk about preventive maintenance and we're talking about professional care, of course, the patient's oral hygiene home care is critically important. I told you that was the strongest risk factor. So of course, it's very important for us not to be lazy on oral hygiene instruction. And professionally, we want to remove the plaque and calculus. So I know what you're thinking now. Can we use metallic instruments or do we have to use plastic instruments? We're getting to that in a moment. First, let's talk about mucositis, where there's no true bone loss. It's kind of like similar to gingivitis. We really just need to manage the plaque and contributing factors. Yes, oral hygiene instruction and elimination of any risk factors that are making it more difficult for the patients to carry out their oral hygiene. Now, sometimes that's a problem. Implants may be too close together. Sometimes that's, depending on how the prosthesis fits, that can be a real problem, especially in the maxilla. These full arch fixed prostheses can sometimes be extremely difficult to clean. But we want to design the prosthesis, shape it, do as much as we can to at least give the patient a fighting chance to carry out good home care. So bottom line, peri-implant mucositis can effectively be treated by traditional mechanical therapy. For mucositis, we don't have to start doing antibiotics and lasers and all of this kind of stuff. It's kind of boring, but that's all that's needed for mucositis, and same would go for gingivitis in the natural tooth situation. So manage the plaque and the contributing factors, lots and lots of studies. Again, I'll give a shout out to Sunstar, who's not paying me, but still I want to give them credit. I've always used their products throughout my career, and I think they have great products and a great company. They have specific oral hygiene aids specifically designed for implants. So we're not going into those detailed explanations right now. But I know what you're all thinking. What about that new Gingiblast machine? This is a lecture I gave on perio many years ago. And I guess the dentist wasn't too interested in my lecture, so he's busy drawing a caricature of me using the new Gingiblast machine, which is connected to a fire hydrant, by the way, in this. Anyways, it's quite funny. So what about oral irrigation? I have to tell you that in my career, I wasn't a big fan or proponent of oral irrigation because I felt it can lull the patient to a false sense of security. It can remove food debris, so the patient spits out what they see food debris, but not necessarily remove the sticky, microbial plaque. Having said that, I have to be fair and be non-biased. I did come across this article just a few days ago, just published in 2022. It's a small group, small article, just 15 patients in each group. It's not the be all and end all final, jury is still out on this, but they did find that the group with the oral irrigation and the toothbrush had the best results. For what it's worth, I throw it out there. More work needs to be done. What about professional debridement? And you'll notice here I'm showing metal scalers, and just like the metal probe, we've dogmatically, many of us been taught you're not allowed to use a metal scaler on an implant surface. And this comes from, some older studies that can show a benchtop study that a metal scaler can cause these scratch lines in a pure titanium abutment. Pure titanium is the softest metal. Today, probably none of the components are pure titanium on the abutments. They're probably much harder metals, but that aside, what can we use? What about the implant surface? And here's one of those scanning electron microscope studies that certainly can show you can cause scratches. However, the bottom line is, does it affect the clinical results? That's really the bottom line. And the bottom line, again, it's one of these meta-analysis and systematic reviews. Bottom line is they couldn't show any deleterious effects clinically, even when metal scalers were being used. There wasn't more inflammation or more peri-implantitis because the implants, the abutment surfaces were getting scratched up and were more plaque retentive. So this has become a dogmatic theoretical concern, but research studies have not borne this out. So the bottom line, I'm just quoting you a few of these studies, that even when they were debrided with metallic instruments, plastic instruments, all compared, there were really no significant differences at the end of the day. And this is an image from that study showing you if they applied bacteria after the surface treatments, if there was no treatment, yeah, there was more bacteria, but whether it was metal scalers or plastic scalers, the amount of bacteria that accumulated on these surfaces was pretty much no difference between them. So horror of horrors, we shouldn't be too concerned about using metal probes and even metal scalers. If you want to compromise, you could use maybe a titanium scaler, which is not as hard as a stainless steel one, but still feels and functions similar to metal instruments. But I think gone are the days of using these cumbersome and ineffective plastic scalers. So let's continue now with treatment, and we have to differentiate treating mucositis, which we've talked about is basically black control and the associated risk factors. We haven't really talked about treating peri-implantitis, where we have true bone loss. And we're coming really towards the last section of our presentation here. So let's look at mucositis on the left and peri-implantitis on the right and look at these various treatment modalities and which ones apply. Well, certainly scaling, oral hygiene. Well, certainly oral hygiene for mucositis. What about mouth rinses? Again, it doesn't hurt to use them. Some studies have shown some additional benefit. Lasers, again, I can't say I'm a laser expert. We tried lasers in our practice briefly. There are people much more knowledgeable than me when it comes to lasers, but looking at the literature critically, I can't really say that we've seen any real strong evidence for the beneficial use of lasers above and beyond the traditional treatments. Antibiotics is not indicated for mucositis. Surgery would not be indicated for mucositis. Now, with peri-implantitis, scaling and oral hygiene certainly can be incorporated. The reason there's a question mark there is it's typically not enough to control significant peri-implantitis where you have quite a bit of bone loss and pocket depth. Rinses are not going to do the job. Lasers like before, despite some strong proponents, my analysis of the literature looking critically, I don't see strong evidence for it. Antibiotics can maybe be a help, but not enough on its own. Sometimes we really need surgery when it comes to peri-implantitis. And as I mentioned, scaling and oral hygiene initially is fine, but maybe not good enough on its own. So surgery we might consider for peri-implantitis, but certainly not for mucositis. And again, I want to give a credit to my colleague and friend, Mark Nicolucci. He actually was the fellow who bought my practice several years ago. He's written several articles, and one of them was on peri-implantitis treatment options. And the slide, he's sort of an expert on a special technique that involves what I'll call implantoplasty, which I'll show you in a moment what that is. And the cases I'm going to show you are his cases. So here we have a case where the flap is opened and there's actually a lot of granulation tissue here. That's kind of soft, mushy stuff, not bone. So by the time you clean all the soft, mushy stuff away, here's what you're looking at. So the implant is not mobile, it's integrated. An implant can have even just 5 or 10% of the bone left and it won't be mobile. So this implant has significant bone loss, but an attempt is going to be tried to make to save it. So you got to clean it out. Now, how are you going to clean out all the bacteria, debris that's in between these threads? Well, one way to do it is to take a drill and just drill off the threads. And we're going to call that implantoplasty. So if you're worried about scratching an implant surface with a metal scaler, and you look at what Dr. Nicolucci is doing here with a high-speed burr, it makes me chuckle. So you can see here that on the radiograph, the threads have been drilled off down to the area where the bone defect ends. And this is the smooth part, that, well, relatively smooth, but that's just a radiograph. He'll now fill this defect with a bone graft and maybe cover it with a membrane of some sort. So that gets into a little more surgical detail. So there's your bone graft in place after the implantoplasty. And now he trims the membrane and that'll go around the neck of the implant, almost like a bib, like when you eat a lobster. And that's the bone graft material. And he's had some really good results, at least radiographically and clinically with these treatments, but it's not going to be successful 100% of the time. So that treatment we'll call surgical treatment with implantoplasty. And what the benefits to this particular portion of the treatment? Well, there's no question you're decontaminating the implant surface. You're creating, let's call it a relatively smooth surface. And by reducing those implant threads, you're decreasing the diameter of the implant, making it more what we call within the bony housing. So when you're doing a bone graft and a membrane on top of that, when things are more within the bony housing, there's a better chance of new bone formation. Some of the disadvantages or problems when you're drilling off those threads, you can overheat the implant. Remember I showed you that case where we had all that bone loss from the implant being overheated? You're releasing a lot of titanium particles into the bone tissue. And we're going to talk about that a little more. And if the implant's a narrow diameter implant to start with, you can significantly weaken it, that it may be prone to fracture by taking off a lot of that titanium. So let's just show you a couple of more cases before I go into some of those details. Again, upper left is after debridement, upper right after implantoplasty, upper left pre-grafted radiograph, sorry, lower left, lower right with the graft in place. Another case, in case you haven't seen enough, after debridement before implantoplasty, upper right after implantoplasty, lower left after implantoplasty before graft, and after. So let's look at some of the literature. Does this stuff work? Well, here again is another one of these systematic reviews, 14 studies combined, stating with this technique that I've just shown you, improvements in bleeding and peri-implantitis. I'm giving you some very general, broad conclusions. Another systematic, you'll notice these are very recent systematic reviews. I've spent a good part of my summer here, winter, I'm in Florida, it's hot, updating a lot of these slides. So another, 8 studies combined, similar conclusions with improved conditions and good results. Another 2021 study, again, showing you what they term successful results. But what about the negative stuff? Here's a risk for fracture if you do this implantoplasty with narrow diameter implants. So I mentioned that. And what about this release of titanium particles? Maybe we should talk about this a little more, because even with hip prostheses, In the past, sometimes they were made out of chrome cobalt, and there were people getting toxicity and hypersensitivity reactions with rashes all over their body. So if you have a titanium alloy where there's aluminum and stuff in there, there is some discussion about, well, is there a potential for toxicity to the patient, systemic toxicity, if too many of these corrosion products are released into the body's tissues. And through natural wear, you get some corrosion products being released. But when you do implantoplasty, you're multiplying that 100 or 1,000-fold, who knows? Is that a concern? It might be, it might be. So here's another study that looked at this. And this is with titanium alloy implants. Some of them are not alloys, some of them are grade 3, grade 4. Grade 5 is alloy, and that has vanadium and aluminum in it, call those G5 implants. They say maybe you shouldn't use alloy implants for this reason, concern of cytotoxicity of the vanadium. And in the past, there was talk about concern about the aluminum. It's there in small quantity, but some people feel it is a concern. And here again, another systematic literature review on showing fibroblast toxicity. This is the aluminum alloy, was a concern with potential fibroblast cytotoxicity. So again, the jury is still out on this. I just throw it out there that with this implantoplasty technique, if it's an alloy implant, it is something that maybe we should think about twice. Okay, next question. We have 3 in a row here, the last 3 questions, and then we're just going to summarize. What is the best treatment for implant mucositis? Not peri-implantitis, just mucositis. Oral hygiene and scaling. Scaling only with non-metallic scalers. Routine use of lasers. Surgical therapy. Or all the above, or none of the above. This one's a little trickier. Little hint. How are we doing, Carla?
We're at about 64%, so we'll just give it another.
Yeah, this one's a little tougher. I'm getting nasty and tough in my old age.
Okay, so I will end the poll now and share the results.
Wow, I'm impressed. A is the right answer because oral hygiene and scaling, it can be used for mucositis, but scaling only with non-metallic scalers. I just finished saying we can use metallic scalers, so throw that one out. Routine use of lasers, I mentioned in my opinion, there's no routine use of lasers justified, and we wouldn't do surgical therapy for mucositis. So A would be the best answer in my opinion. Next question, what is the best answer? Treatment this time for peri-implantitis. Oral hygiene, routine use of lasers, antibiotics if indicated, surgery if indicated, all the above, or A, C, and D.
Oh, give it a few more seconds. Okay, so I will end this poll
Okay.
and share the results.
F, in my opinion, is the best answer because B, I would not include. Routine use of lasers is not something that is evidence-based, in my opinion. Last question, what is the best answer? Implantoplasty for surgery, for implants, for implant peri-implantitis. Does it decontaminate the surface, smoothen the surface? It may generate heat, it may weaken the implant, and it may increase particle release, or all of the above.
Give it another 15 seconds or so. Okay, so we'll end the poll. And here are the results.
Excellent. All of the above. Okay, terrific. So let's just wind up summary and review. We've touched upon the recognition, prevalence, etiology, risk factors, prevention, and treatment for peri-implantitis. On the recognition, we need to differentiate between mucositis and peri-implantitis by a combination of, in our examination, visually looking at everything, checking for mobility, probing, looking at radiographs. Remember that with bone loss, we talked about 5 potential clinical effects: increasing periodontal attachment loss, aesthetic sequela, potentially implant loss, even implant fracture or mandibular fracture, with less and less severity as that list went on. Prevalence increases over time. Mucositis sometimes can be over 50%. Peri-implantitis may be over 25%. And a lot of that depends on how long ago the patients had their implants placed and a bunch of those risk factors that we talked about. In terms of those risk factors and etiology, remember I showed you this slide, the number of check marks indicates the strength of the association of the risk factor with possibility of peri-implantitis. The ones we talked about today were the plaque control, the implant design and surface, the prosthesis fit, and iatrogenic situations such as excess residual cement. Those are the only ones we have covered today. In terms of prevention and treatment, we talked about what is appropriate for mucositis, what is appropriate for peri-implantitis. So again, I want to thank TMFD and hope that you join us for more of the TMFD Dental Academy webinars we have. They're usually about 50% clinical dentistry topics, 50% practice management, financial type topics. I want to remind you that if any of you want any of my article reprints to be emailed to you, to drop me an email at murray@murrayarland.com. Also, if you have any questions about my experiences as being a TMFD, satisfied client, please do contact me. I'd be more than happy to speak to you. I can't emphasize strongly enough for all of you prospective clients that give yourself the chance to check them out. I guarantee that you won't be sorry. But again, they're not paying me to say that. I hope I haven't bored you. I've tried to make it interesting. If you have any questions, please don't be shy to post them now. If you haven't already, we'll give it an extra minute or two. And Dr. Tug and Dr. Yank would like to answer your questions, and I'll answer on their behalf. So thank you once again. Take over, Zach.
Perfect. Thank you, Dr. Arlen. There's a few questions here for you, so we'll still be needing your expertise for a few more minutes. So the first question, how do you manage a loose cemented type of implant crown? Cutting the crown off, is that the only option?
Very good question. First thing you want to do is you want to try to diagnose what's loose. Of course, if it's just a loose cement seal, you can hopefully get the crown off, and that's the easy solution. Most commonly what happens is the abutment screw is loose, but the crown is solidly cemented on the abutment. If you're smart or lucky, you may still have the study model to have a general idea where that abutment screw is. And you try to drill a hole through the occlusal surface of the crown and hopefully be able to find that abutment screw, and then just tighten the abutment screw and just fill in the access hole. And that's the most common situation. Of course, if it's a loose if it's a broken abutment screw, or if the implant, then you're going to get the crown off, and the broken piece will still be left inside the implant. And sometimes we can get that broken piece out. There are special kits for that. If it's the implant itself that's disintegrated, you can usually tell that as you diagnose it. As you luxate back and forth, the patient will feel some deep-seated pain. You may see a radiolucent line around the implant. So then, of course, the whole implant has to come out. But the most common scenario is the loose abutment screw. And hopefully, by drilling a hole through the crown, you can find the head of the screw, tighten it, or preferably replace the abutment screw and salvage the case. If you can't, you may have to cut the crown off and make a new crown. Yeah.
Thank you, Dr. Arlen. Next question is, how often do you encounter open contacts between implant crowns and adjacent natural teeth? Does the open contact usually happen at the mesial of the implant crown?
It's a great question, and it's a tough question. And I have to admit, I don't really know that I have the answer to that. I've seen anecdotal references to open contacts developing. I think the most common explanation that I found is there's a tendency over the years for there to be interproximal wear and mesial migration of the natural teeth. Of course, the implant does not move at all orthodontically, so the most common would be to find the contact on the mesial aspect of the crown. I don't really have more information on that, but that is something I've seen reference to rarely in the past. So a good but tough question.
Next question is, since probing can be inaccurate for implants, how often do you do probing around implants? As needed when there are symptoms, or yearly at the same time for natural teeth?
Again, I think that it depends on the degree of accuracy you feel you can impart to your probing. If you've got, for example, a full arch maxillary prosthesis that's ridge lapped, it's just, there's no point in even trying, because your probing measurements are so inaccurate, they're really meaningless. So again, I would rely on good quality periodic radiographs to try to monitor for any ongoing bone loss that's taking place. If you can get good access and probe accurately, then I see nothing wrong with probing on an annual basis and reporting it just like you would with a natural tooth. Certainly, if you're seeing signs of bleeding and suppuration and swelling, we would definitely, want to probe. Give one example: if you have a situation where you've lost the labial plate of bone, you may not see that on a radiograph, and the implant may not be mobile if the rest of the circumferential bone's intact. But you might pick up a 15mm mid-labial narrow pocket. That there's no other way to diagnose that. So there is a place for probing in those kind of situations.
Perfect. The next question comes from Dr. Simmons. Is implantoplasty okay if only one side of implant is compromised?
Most of the time that is the situation. Most of the time the facial bone is thinner than the lingual bone or palatal bone. And 9 times out of 10, the defect is typically exposed threads on the facial aspect of the implant, and it may go interproximally to a variable degree. So typically you're only doing the implantoplasty where the threads are exposed, wherever that may be. Most of the time it will be on the facial aspect.
Is
So
there
the key there is you only do the implantoplasty where the threads are exposed.
the next one is there a higher success with less implant reduction?
I would say there's no studies on that. These procedures that are done are mostly just isolated case reports. There's too many variables to really draw any scientific conclusions on the intricacies of, which works better than other techniques. So it's very unscientific, and we just don't have the details to know the particulars of what kind of bird to use and all that kind. It's very it's a bit of a wild west, when it comes to that kind of stuff. It's more art and less science, I would say, at this point in time.
Mm-hmm. Next question from Dr. Lee is for surgical intervention treatment of peri-implantitis. Can you please discuss about flap design?
I really think that's probably not within the scope of this lecture, but I would say, very simply, it's nothing fancy. You're doing your sulcular incision with a full thickness flap. You need to get access to the area. You have to see what you're doing. So you're just basically raising a full thickness flap. You're often going to do bone grafting and a membrane. So you need to elevate your flap aggressively enough that you can close it without tension to keep the bone graft and the membrane covered during healing. So I think those would be the main points for flap design.
And then do you graft on the lingual too and biomaterials?
If there's no bone loss, you're not touching that area. You're not doing implantoplasty, you're not grafting. Wherever the bone loss is, you're doing the implantoplasty, the bone grafting, the membrane. Wherever the bone loss occurs, that's where you're treating.
Perfect. And then do you use carbide or diamond burrs for implantoplasty? And after the plasty, do you use any chemical solutions to further decontaminate the implant surface?
Again, there's been a lot of research on using citric acid. Some people have shown that that's a good solution. Others will use lasers. Others will use saline. There is no solid scientific evidence to say this is the magic bullet. Everybody seems to have their own formula, their own burr, their own solution to use. And what that tells you is none of them is scientifically proven. So I can't say there's anything specific I could recommend based on solid science.
Perfect, thank you. And if gridding off threads is risky, is there any pharmacological or chemical treatment suggestion?
Again, the risks involve overheating, weakening the implant if it's a narrow implant, and release of vanadium or maybe aluminum particles if it's an alloy. So if none of those three things apply, you're careful not to overheat the implant. I don't think there's much danger. But again, if you're not going to do implantoplasty, and a lot of people do not, you're going to have a very difficult time trying to debride the area properly. And you probably won't be able to debride the area properly. And again, as I said before, some people use citric acid, some people use lasers, some people use saline. There is no solid scientific data to show that one is clearly superior over the other.
Perfect. And why are SLA implants more successful than TPS?
Yeah, great question. So again, the Straumann company started off with what's called the TPS, standing for titanium plasma spray, which was a very rough surface. they discontinued that in around 1995 or 1997 and introduced a new surface that was, instead of very rough, we'll call it medium rough. So the very rough surfaces like TPS and others like hydroxyapatite coated were very good for early bone bonding, but if they became exposed, were very bad for plaque retention because of their very rough surface. So like sandpaper, they would, you couldn't clean the plaque off of them. So the difference is that the very rough surfaces were too rough, and in modern times, all the implant companies are using what we'll call medium rough surfaces. So the same pattern has been shown with other companies changing their surfaces as well.
And what is your experience in implant to tooth bridges? Any way to predict complications?
Again, off topic and a whole lecture on its own. Short-term studies of less than 10 years have shown comparable results to implant bridges, but some of the longer-term studies that go 10 years and beyond have shown about a 25% complication rate. The most common problems being decay and fracture of the natural tooth segment on that combined implant to natural tooth bridge. So it can be done but I would say it's your second choice. If you can do implant to implant, I still think that's the way to go. Implant to tooth is not an absolute contraindication, but likely has longer term, more complications related to the failure of the natural tooth part of the splint.
Perfect. The next question, what is the frequency recommendation for scaling and root planning for patients with or without implantitis?
Well, again, something that you have to obviously fine tune to the needs of the patient. I mean, frankly, how often should a patient with natural teeth be seen? If they come in every time with not an ounce of plaque, not a bit of plaque, or not a bit of gingivitis, do they really need to be seen every 6 months? Probably not. They can probably come in once every couple of years safely. Other patients who have poor plaque control, maybe some deeper pockets you're trying to maintain, you want to be seen on a 3-month basis. So I think you have to customize the interval to the individual patient's needs. So, you know, I think once every 3 months for a patient with risk factors and peri-implantitis is reasonable. And 6 months to a year or more for patients who have shown a long-term history of perfect health.
Next is, what is your personal view on the success of bone grafting around implants that have lost bone? And how do you verbalize possible expectations for outcome to patients given the generalized unpredictability of the endpoint?
So you've asked the question and you've answered it yourself. You've asked what's the predictability of bone grafting, and the second half of your question is you said it's unpredictable. So I agree with you. It's not a very predictable procedure. And just like anything you do with a patient that doesn't have an excellent prognosis, it's called informed consent. You have to give the patient your honest appraisal of what are the chances of success, of lack of patient symptoms, if the implant will be there in 5 and 10 years from now. And you know, between you and the patient, you have to decide if that kind of outlook is worth going through the procedure. It's all a question of being honest with yourself and being honest with the patient. But I do agree with you. These, I showed you a case before of those 2 implants were at risk for mandibular fracture. I mean, you know, if it's a hopeless situation, I don't think it's ethical for you to start doing these bone grafts when in your heart, you know that it's not going to work. So the more advanced the bone loss gets, the less likely the treatment's going to help those implants last the patient's lifetime. So honesty and informed consent. But I do agree, these regenerative procedures are not that predictable.
Perfect. And the last question, in your experience, what are the top 5 brands of implants that show the least amount of implantitis?
Really tough questions. You know, I would say the implants in my experience that I found to have the best, the lowest incident of peri-implantitis or highest degrees of success, the brands that come to mind. The Straumann, SLA and SL Active is probably the best researched on the market. They purchased the Neodent system. In my experience with Neodent, that was a very good system. Astrotech has a lot of studies showing that they claim less bone loss than any other implant system on the market. So those studies are published by Astrotech employees, for lack of a better word. So you've got to have a little bit of caution when you're looking at who's writing these articles. But Astrotech's a good company with little bone loss. MIS was pretty good. There's another company that's very prominent in the marketplace that I've left out on purpose because I feel they don't belong on that list, and I won't mention the name, but everyone out there will know what I'm talking about.
Thank you. That's the last question that we had. Anyone else who has any additional questions, like you mentioned, can reach you at Murray.
I'm very impressed by the number of questions we have. Never had so many questions. I thought we'd be going here till 9:30 or 10 o'clock. Maybe those 26 chat things were 26 questions the way we were going at them. Okay, thanks Zach, and thanks Carla. Thank you to TMFD. Thank you all for attending. And remember, feel free to drop me an email if you want any of those articles or to discuss TMFD or anything else for that matter.
Thank you, Dr. Arlen. Thank you to all the attendees who have joined us this evening. Our next event is March the 23rd at 7 o'clock. It is the 4 phases of retirement and psychological change with Dr. Riley Moynes. We look forward to seeing you then. And again, thank you, Dr. Arlen, for the amazing presentation and for the very detailed responses to all these questions that everyone was trying to challenge you with.
It's okay. It's good. Good stuff. Thank you very much.
Thank you, everyone.
Thank you, everyone.
Good night.
Thank you.